The first presentation by Dr. Pedro Moreno, who is the Director of Quality Assurance for Mount Sinai Heart, and he's a professor of medicine and a great interventionalist. He will talk about the vulnerable plaque, the evolving concepts. Pedro?
Thank you, Dr. Sharma, and thank you all for being here. This is my disclosure. I'm a speaker for Abbott. And the vulnerable plaque is an old friend that has been forgotten in the last 5 years because of a lot of controversies regarding diagnosis and therapy. However, I have to say that procrastination is the art of keeping up with yesterday. So welcome to the past with a fresh view to the future. My presentation is divided into 4 steps. One is just a case that is illustrate the issue, the definition, natural history studies, and therapy. So we start with a 56-year-old gentleman who had some fatigue and exertion, but denied chest pain. No shortness of breath, no palpitations. Almost asymptomatic guy, but had a high calcium score. He had some risk factors as shown in the slide, and his medications were aspirin, metoprolol, and atorvastatin. His exam was totally normal, and his electrocardiogram is showing the slide, show a normal sinus rhythm with basically not significant changes. The echocardiogram was also very benign with just mild concentric hypertrophy with a normal ejection fraction, and his carotid ultrasound was also very benign. He did have a coronary calcium score that was 2200. This is a case that was here in the lab last week. And his initial angiogram, as shown in the slide, show a pretty good coronary angiogram, maybe some irregularities in the circumflex. We're gonna see the cranial projection for the LAD, calcium, mild to moderate disease. And the RCA was a little bit more interesting, also with calcification and some moderate disease, like we call multiple segmental areas of moderate disease, mild to moderate disease. So here we are, an asymptomatic patient diagnosed with CT angio. What do we do now? No stress test. We go ahead and do FFR. And the FFR was done actually by Dr. Sharma, who is the principal operator of this case, who showed no significant RCA disease. The patient was sent home. The primary care physician took excellent care of this, the cardiologist, and doubled the atorvastatin to 40. And the patient comes back 2 months after with ST segment elevation. The lipid profile on admission show an LDL cholesterol of 58, so very good, below 70. And this is the angiogram. If anybody can guess where the lesion is, we'll give you an extra dinner tonight. The LAD was exactly the same. The RCA was exactly the same. And the culprit was actually the circumflex artery. You can tell ST elevation, 99%, probably reperfused, successfully stented by Dr. Sharma.
No.
So in summary, you want to say something that says?
Yeah. No, actually 2 things. One of the patient belongs to one of our physicians who has signed in, and Fantastic. It was done outside. The angiogram was done, or the PCI was done out of the hospital. Just wanted to correct that.
Oh, okay. So the issue here, yeah, very good. The issue here is that we have a middle-aged gentleman with a high calcium, no significant CAD, was presented 2 months after with a stem. Is this the vulnerable plaque? Well, let's talk about it. The definition, multiple testing, multiple definitions, anatomy, OCT, thermography, elastography, virtual histology, CT angio. This is another case, the same thing. Look at the CT angio here, 54-year-old diabetic with a BMI of 45, normal EKG a year after, boom, here we go. The same problem ended up with a stroke, AEF of 20%. So this is a real thing. Even if we wanted to address it, this is a real thing. And what is the natural history of this? This is key. We're going to present a few trials that have actually shown prospective data. And the first one was by Motoyama in 2009 that identified the low attenuated plaque, which is the Hounsfield units are below 50. So it's radiolucent. That means it's full of lipid. And you have positive remodeling. And those plaques on this data from Japan show if you have both, you have an ACS event at 50 months of 22%. And the incidence, though, is only 4.3%. So it's rare. It's not that common, 1 in 20 or 1 in 25, but the outcome is not good. The second very important trial is the Prospect trial that was run by Roxana, who's here tonight, and also Greg Stone, PI. And after fixing obstructive lesions in non-STEMI patients, they went after the non-obstructive lesion with IVUS and virtual histology to identify the thin cap fibroateroma, showing the red, which is the necrotic core very close to the lumen, minimal luminal area less than 4 millimeters square, and a plaque burden greater than 70, all of them independent predictors for events. The interesting thing is that each of them were statistically significant, but if you have the aggregate of the 3 of them, you have 17.2% event rate at 3.4 years. Again, the incidence less than 5%. So 2 studies showing high incidence of MACE at 3 years or less, and the same prevalence of about 5%. Now, the third study, natural history study, is called the lipid-rich trial. And this was done using a technology by the name of spectroscopy, near-infrared spectroscopy, who uses light in the near-infrared wavelength. And this catheter was developed when I was in the University of Kentucky. I was hired after fellowship by Dr. Jim Muller with a $10 million grant he had to develop this program. And we identified that this technique actually is very good for necrotic core, not very good for thin cap, not good for macrophages. We created this, this is the patent that was developed by this technology. And then the FDA approved it in 2008. Basically, it's a catheter that identifies the lipid-rich area, and it does it in some units called the lipid core burden index. So the lipid core burden index can go from 1 to 999. And investigators showed that during the STEMI, the LCBI, lipid core burden index, was usually greater than 400. This is data from Madden, and this is data from Dr. Erling that was presented a few years ago. All of these are STEMIs, all of them, like 98% of them with very high LCBI. So the lipid-rich trial was a trial to follow, identify patients with vulnerable plaque for future coronary events using this technology. And what is interesting is that if you have a maximum LCBI greater than 400, your cumulative non-culprit lesion MACE incidence was very high, up to 14%, compared to if your non-culprit lesion doesn't have much lipid. Then it comes the study number 4, which is Prospect 2, recently presented at TCT by the investigator that shows the LCBI in the STEMIs. And here we go. If you have maximal LCBI greater than 324, which was the highest quartile, you have 10% events. This is patient level events. This is lesion level events. In both patient level or lesion level, your OR odd ratios are double or up to 7 times if you have these high lipid-rich plaques. Same for plaque burden by IVUS. Same for 11% if your plaque burden is greater than 70 versus 3% if your plaque burden is less than 70. And the lesion level events 4 and 0.4%. Now we go to the last natural history study that was also presented at TCT, and this is a very interesting concept, joining OCT for fibrous cap thickness and FFR. We're looking at the importance of plaque composition in the absence of hemodynamic or functional significance. And it was in a high-risk population, patients diabetic with ACS. If the FFR was greater than 0.8, non-obstructive, non-significant. You have a group A, which is TIGFA negative. That means they think the fibrous cap is greater than 65 microns. And if you have lower than 65 microns, then you call it group B or TIGFA positive. And of course, the ones that had obstructive disease got stented. It's called the combined OCT FFR trial. And here we go. You have the non-culprit lesion by IBUS criteria, 11 and 3.6%, 4.6, 0.4. And here, the maximal LCBI, 10%, 4.8, 3.8, and 0.5. So 4 studies showing that if you have lipid-rich lesions with thin fibrous cap or not thin fibrous cap, but lipid-rich, positive remodeling with a plaque burden greater than 70, you're in trouble. The question is if you can actually go for it. The question is, how do you treat this? So you have 2 options. You have medical therapy, that's statins and PCSK9 inhibitors, or you can put a stent. This second part is 100% hypothesis. Of course, you're not going to put a stent at this particular moment, but there's a study that I'm going to share with you that did that. Let's go with the statin therapy. You can reduce the plaque burden dramatically from 10.6 here to 6.8 millimeters square if you get an LDL cholesterol below 70. This is the asteroid trial. If you go between 80 to 90, you do nothing. And if your LDL is greater than 90, plaque progress. So in order to do stabilize or regress, you need an LDL below 70. What about PCSK9? Sorry about this. PCSK9 are here. I'm sorry, this is lipid core. This is the yellow trial that was developed by Dr. Kinney and by the group here at Mount Sinai. And the hypothesis was that if you do aggressive therapy and you repeat the evaluation with the lipid core burden index, you can see that in the high aggressively treated patients, you have a reduction of the lipid core burden index that is significant. 154 points. This is an example. The lesion is obstructed by FFR. The lumen is, the plaque area is 5.6. And this is the LCBI, 802. You treat the patient for 7 weeks. You bring the patient back to the cath lab to do the stage intervention of this LAD. You do the FFR is still significant. The plaque area is unchanged, but the plaque burden is reduced to 50%. So in 7 to 8 weeks, you can change the morphology, the composition of the plaque and probably the activity, the metabolic activity of the plaque. With Dr. Kinney as well, the Yellow 2 trial was also published in JACC just to identify thin fibrous cap, the same hypothesis as the combined investigators did for TCT. And yeah, there we go. We started with a thin fibrous cap of 50 microns in the group, and we finished with thin fibrous cap up to 90 microns, showing that aggressive medical therapy stabilized these high-risk plaques. PCSK9, same story. You drop the LDL lower than 60, and you have dramatic reduction in percent atheroma volume. This is the GLAGOV trial with evolocumab, published by Steve Nissen. And finally, we're going to talk about the stents. This concept of the stent was developed by research that we did on highly lipid fed rabbits, New Zealand rabbits. For 4 years, they developed this vulnerable plaque that was almost indistinguishable from human VP in pathology. You put the stent in, you have the old fibrous cap here, but you develop a new fibrous cap because of the neointima. So we call it new cap area or new fibrous cap. Okay, so of course this plaque is reinforced. They have no more Achilles heel. If it's endothelialized, the plaque is stable. Of course, there is a risk for putting the stent. So that was what Greg Stone did in addition with all these investigators, with the prospect absorb investigators. What is the concept? The concept is here with the lipid-rich plaque. If you put a stent, you develop this neocap, and you may prevent complications that if you don't put the stent. That's the whole hypothesis. Easy to understand. It's a subgroup of only 182 patients from the prospect 2, and they were randomized to BVS, bioabsorbable stent, with guideline-directed medical therapy versus just medical therapy. And the interesting concept is that your minimal luminal area, in other words, the lumen, not the donut, but the whole of the donut, before and after stenting increases dramatically with the stent. Of course, you get rid of the plaque. So you improve your lumen, and it's sustained. It's sustained after 25 months. This is baseline and the follow-up. And this is across the entire lesion, including the 5mm margins, is increased as well. So you do, morphologically, you do better with lumen-wise with the stent than if you don't put a stent because there was a plaque there. The important thing is what happened to MACE. And MACE was 10.7% with the guideline directed medical therapy alone in these high-risk plaques with the near infrared, and 4.3% if you put the stent. So there is a significant difference, but the p-value is not, I wouldn't say not significant. It is an interesting difference that is certainly hypothesis generating for the Prospect 3 trial that is under design. So the take-home message is BVS implantation in angiographically mild to non-flow limited lesions with a large plaque burden, small lumen, and high lipid content was safe and substantially enlarged lumen dimension during the follow-up, and the favorable randomized lesion-related MACE rates observed after BVS warrants the performance of an adequately powered randomized clinical trial to determine whether PCI treatment of focal vulnerable plaques improve patient outcomes. With this, I want to thank you and wish you the best holidays ever. Thank you so much.
So now one other question which Pedro may be on the line, it is a very interesting one, and that is, how do we combine, understand the ischemia trial data and the STIGFA concept in practical terms for appropriateness? Patient comes in having angina, 50%, you may do a OCT or IVUS and it's a TIGFA. What do you do? I know that this is a very valid question, and the question always also that 50% lesion, FFR is okay. So do you need to do anything further?
Beautiful. So ischemia trial in clinical practice and the vulnerable plaque. So the ischemia trial did not include imaging or functional testing. Very little functional testing is if any. As such, the exploration for vulnerable plaque was not done. Therefore, the TIGFA concept is really non-existent in the ischemia trial. It's buried somewhere, but not clinically explored. So TIGFA, as defined as non-obstructive high-risk lesion, is not considered in the appropriateness criteria either. Because the appropriateness criteria is evidence-based on randomized trials, so we don't have that yet. However, how do we integrate with the concept of TIGFA can be integrated in clinical practice when documented by CTA or by intravascular imaging? Now, to reduce future MACE in these patients, they really need a very, very careful surveillance with an LDL ideally lower than 50, and by imaging, of course, non-invasive with CTA to evaluate further progression on remodeling, the low attenuation, Hounsfield units, and the minimal luminal area and FFR by CT. So if you identify these plaques somewhere or the other, you need to aggressively install emergent therapy to drop the LDL to 60, as Dr. Kinney and Sharma and I did with the yellow trial, and then double check with the CT angio. That's the way I think it should be done.
Beautiful. Good.